attendees on the floor, we're going for the next speaker. We'll welcome Prof. Dr. Muhammad Imad, the head of department from basic medical science. So with academic qualification, he's graduated from the master degrees University of Baghdad, and later on continued his doctoral philosophy in microbiology in University of Sheffield. And he's also a multiple board member of Medical Association and Microbiology in Iraq, Australia, and even European Society. So we are glad and honored to have Prof. Imad to come and teach us for the next lecture. So if no problem with your connection, I think we can proceed, Prof.
Okay, thank you very much. I'm trying to share my screen. Share screen. Okay, you can see my screen now?
Yes, Prof.
Okay, fine. Okay, assalamu alaikum wa rahmatullahi wa barakatuh, and good morning to everyone. I think you are overwhelmed by all these talks, but what to do? We have to do it. So the topic that I'm going to talk about is about systemic inflammatory response syndrome, which might lead eventually to multiple organ dysfunction syndrome, especially if there is infection that is not controlled, leading to sepsis, septicemia, and septic shock. Now, we are going to talk about sequential organ failure assessment, which is the replacement actually for the systemic inflammatory response syndrome, the SIRS assessment. People think that this sequential organ failure assessment is a better indicator of in-hospital patient mortality. So nowadays, people prefer to use the sequential organ failure assessment, what's called SOFA, and also quick SOFA. And there are calculators in the internet for assessment for this kind of assessment. So background about SIRS and MODS. In 1992, American College of Chest Physicians, Society of Critical Care Medicine introduced these definitions: this SIRS, sepsis, severe sepsis, septic shock, and multiple organ dysfunction syndrome. And the idea was to define actually a clinical response to non-specific insult. It can be specific, of course, if you know what is the insult, but it can occur due to various types of insult, whether infectious insults or non-infectious, due to tissue damage or whatever is the cause. So this diagram actually shows the interrelationship between all these terminologies that we have mentioned. Here we have SIRS, which is the initial inflammatory response, and it is preceded by S, which stands for systemic. Usually, if there is an infection or an insult, it is localized, so the response will be localized inflammatory response. And you know, inflammation is very important mechanism by which the body can overcome infectious agents or can repair eventually damage to tissues. So the local inflammatory response is normal, but when it becomes systemic inflammatory response, then it might cause damage more than help actually. Now, if this is accompanied by infections, whether bacterial infections or other types of infections, fungal infections, parasitic virus infections, or other types of infections, then it might lead to what's called sepsis. And sepsis can be graded, and the most severe form, of course, is septic shock. So original SEERS was defined as presence of 2 or more of the following variables in the patient. First of all is fever of more than 38 or less than 36. So either there is a reaction to the damage in the tissues, so the temperature is increased due to a release of endogenous pyrogens, or the patient is overwhelmed and then the temperature will be lower than normal, 36 degrees or lower. Heart rate, more than 90 beats per minute. Respiratory rate of more than 20 breaths per minute. Of course, the normal is 12 to 15, isn't it? And the arterial carbon dioxide tension is less than 32 millimeters Hg. The partial pressure of carbon dioxide, meaning due to washing out of CO2 due to hyperventilation. The fourth criterion is abnormal white blood cell count, which can be either high, 12,000 or more, or less than 4,000, or the presence of immature neutrophils released from the reserve in the bone marrow, where the nucleus in the form of a band, so they are called band forms. These are immature neutrophils. So if you see more than 10% of these immature neutrophils or band forms, then this is again another criterion for diagnosis of SEERS. MODS, which stand for multi-organ disorder syndrome, is a state of pathophysiologic derangement in which organ function is not capable of maintaining homeostasis, meaning actually failure of organ function. And it is a failure of multiple organs rather than a single organ. So some terminologies again: bacteremia, sepsis, septic shock. You know what is infection, you know what is bacteremia. Sepsis is the systemic response to infections and is defined as presence of SEERS plus documented or presumed infection. So not necessarily yet documented, but there is a clinical evidence of infection that make you suspect or highly suspect presence of infection. Severe sepsis meets the above criteria, meaning meets sepsis criteria, and is associated with organ dysfunction, hypoperfusion, or hypotension. Organ hypoperfusion or tissue hypoperfusion, and usually hypotension due to the vasodilatation that occur in these patients and the inability of the heart to exert enough pressure to perfuse the tissue sufficiently. So it is infection plus SEERS plus MODS. This is considered as severe sepsis. So septic shock is sepsis-induced hypotension and is defined as the presence of systolic blood pressure of less than 90, but in the recent criteria, it is more than 100, less than 100. 90 millimeter Hg or a reduction of more than 40 millimeter mercury from the baseline. So either less than 90 or reduction of more than 40 if you know the baseline beforehand. And this should be in the absence of other causes of hypotension, such as bleeding or other causes of hypotension. So a patient will meet the criteria for septic shock if they have persistent hypotension and hypoperfusion of tissues in spite of adequate fluid resuscitation. And you should know the pathophysiology why adequate fluid resuscitation is not capable of raising the blood pressure in these patients. Some people used to talk about severe SIRS and SIRS shock, which is not nowadays. This is probably in the past. Some people used to talk about severe SIRS or SIRS shock. And they suggest organ dysfunction or refractory hypotension related to ischemic or inflammatory process, rather than to infectious etiology. So if there is no infection, but there is an inflammatory response to tissue damage, then and this lead to organ dysfunction, then it is referred to as severe SIRS or SIRS shock if there is hypotension. Now, potential complications of SIRS include respiratory failure, acute respiratory distress syndrome, renal failure, gastrointestinal bleeding and stress gastritis, anemia. Why anemia should occur? Anybody?
Bone marrow suppression.
Bone marrow suppression, but this is on the long term. If it is acute, okay, we'll talk about later. Deep venous thrombosis, intravenous catheter-related bacteremia, electrolyte abnormalities, hyperglycemia, which can be due to insulin resistance, and disseminated, of course, intravascular coagulation. So pathophysiology of SIRS. So it is systemic inflammatory response. We said inflammatory responses commonly occur due to any form of tissue damage, whether due to infection, trauma, or other conditions that damage tissues. And they have almost the same pathophysiologic properties with some differences. And it is, as we said, it is normal defense, self-defense mechanism if it is localized. But when it becomes systemic, then the issue is there. There might be some damage to the, or malfunction occurs in the host. The inflammatory cascade that occurs is a complex process, and it involves several mechanisms, humoral mechanisms, and cellular responses of the innate immune system, and later on, even the adaptive immune system. Activation of the complement cascade by, if there is a release of acute phase reactants from the liver due to stimulation by certain pro-inflammatory cytokines. This might lead to complement activation if there is, of course, infection, but in SIRS there is not yet infection. Infection can also lead, of course, to complement activation of the complement cascade that will eventually lead to formation of membrane attack complex that can damage endothelial cells of blood vessels. There is activation of various cytokine cascades, pro-inflammatory and also regulatory anti-inflammatory cascades can be initiated and activated. Other humoral cascades, you know, there are many other different other humoral cascades besides the complement cascade. What are these other humoral cascades that you know, of course? What are the other cascading systems in our body and body fluids? Of course, that is coagulation cascade. fibrinolytic cascade, the kinin cascade, and so on. So stages of SEERS, actually, Bohn, one of the fellows who first tackled this condition, summarized the relationship between these complex interactions, inflammatory interactions, anti-inflammatory interactions, and SEERS in the following 3-stage processes. So these 3 stages, processes. Stage 1, where there is local pro-inflammatory response. This is normal, as we said. And usually, if it is not severe, it is mild, it is more moderate, then it is normal. It is important for eliminating the insult, the tissue insult, and also for repair of damaged tissue. So inflammation is very important. So there will be release of cytokines locally. And these cytokines will do their various types of actions in getting rid of infectious agents or removing the insult, getting rid of the insult, and repairing the tissues, damaged tissues. You know what are these? Reticular endothelial system, macrophage phagocytic system, which is recently actually replaced by this terminology, sinusoidal endothelial cell system, because it was found that most particulate matter or macromolecules in the circulation are removed not by the macrophages, especially in the liver, not by the Kupffer cells, but by the sinusoidal endothelial cells. So people now prefer to use this terminology rather than reticular endothelial system, the old one, which is followed by the macrophage phagocytic system. So now we have the sinusoidal endothelial cell system, which is more prominently, at least, involved in removal of foreign or damaged material present in the circulation. So stage 2, which is controlled systemic inflammatory response. So controlled systemic inflammatory response, there is spillage of these pro-inflammatory mediators into the circulation and causing a systemic response, not a localized tissue response, but a systemic response. So this can be controlled by a decrease in pro-inflammatory mediators and release of endogenous antagonists. So for homeostasis, of course, there is pro-inflammatory mediators, and there are also counteracting anti-inflammatory mediators. And you have taken in your immunology course what are the anti-inflammatory cytokines that are released. Then we have stage 3, which is the uncontrolled systemic inflammatory response, which is the more severe form. So in these cases, homeostasis is not restored, and there is a significant systemic reaction, inflammatory reaction with excessive cytokine release, probably leading to cytokine storm that you all know happens in various types of infections, such as, of course, the COVID-19. Some people develop the cytokine storm. And the consequence of this activation, there will be activation of numerous humoral cascades and the activation of these systems and the subsequent loss of circulatory integrity that will lead to end organ dysfunction. Bohn also endorsed later on the multi-hit theory, which is the lead to the progression of SEERS to organ dysfunction and possibly multiple organ damage. So actually, it simply means that this occurs in steps. This condition occurs in steps, and people now they agree that the condition is a continuum. It's not does not occur in separate, well-defined stages, but it is a continuum. So now we have the sequential organ failure assessment, which is now recommended for assessing in-hospital patients for inflammatory response and sepsis, which is called the SOFA, and we have also the quick SOFA. So the criteria for this SOFA, the quick SOFA, are respiratory rate of more of 22 breaths per minute or more, systolic blood pressure of 100 or less, and altered level of consciousness. So this is added, altered level of consciousness due to affection of the central nervous system. So actually, this was devised in 2016 by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, which has a task force that proposed a new definition for sepsis first, which is called sepsis 3, the third definition of sepsis, which is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. And the intensive care unit, especially the intensive care unit mortality prediction score, SOFA, it is mostly applied to intensive care patients, was recommended by the task force due to its superior predictivity of the outcome of these patients rather than the SEERS criteria. So SOFA was endorsed in 2016, as we said, and the following system assessment comprise the SOFA severity score. So the SOFA severity score includes the respiratory system. Regarding the respiratory system, the ratio of arterial oxygen tension to fraction of inspired oxygen is important. The cardiovascular system, mean arterial pressure, and presence of vasopressor medication, whether there is presence, the patient is given any vasopressor medications. Hepatic system, estimation of the bilirubin level, coagulation system, the platelet concentration, and the neurological system, you can use the Glasgow Coma Scale for assessing the neurological system, and then the renal system by estimating serum creatinine and urine output. You know, of course, what is the mean arterial pressure. So if you don't know, or if you have forgotten, this is the formula for mean arterial pressure. We can see this formula depends mostly on diastolic or systolic. What is the most important factor? It is the diastolic, exactly. So criteria for organ dysfunction, pulmonary, we said, you can read all this yourselves, I think, this table, you can read it yourself. You don't have to go through it. This is just X-ray of patient with acute respiratory distress syndrome, where there is bilateral infiltrates in the lungs. And this is the histological picture. And if you want to read more about this SOFA, you can refer to this site. Also, you can refer to Medscape. They have very good review of systemic inflammatory response syndrome, treatment, management, pathophysiology, and so on. Pathophysiology, you know that the immune system, the innate immune system, can recognize foreign antigens and can also recognize damaged tissue, molecules that are released from damaged tissue. So how they can recognize these? So these are recognized by certain receptors. And these receptors are not specific, not like immunoglobulins, not like antibodies, and not like T cells that have specific receptors which can recognize a particular type of antigen. But these receptors recognize pattern. And these patterns are the pathogen-associated molecular pattern, PAM, pathogen-associated molecular pattern, and the DAMP, which is damage-associated molecular patterns, which are endogenous molecules that are released following tissue damage and can be recognized by the receptors. What are these receptors? There are three types of receptors. We have the toll-like receptors, which are present on the cell surface of phagocytic cells mostly, and also some other cells, not only phagocytic cells, macrophages and other cells. So these are the toll-like receptors, and there are several of these toll-like receptors. So it is not a single type toll-like receptors. There are several of them. The number I don't know now is probably more than 10. Then we have the node-like receptors, which stand for nucleotide binding type of receptors. So these are intracellular, and the reason they are intracellular, because once the microorganism is internalized inside the phagocytic cell or other cells, non-phagocytic cells, then to be recognized, you need intracellular receptors. And these receptors mostly recognize the genome of these infectious agents, RNA or DNA. So these are the node-like receptors, NLRs. And then in the serum, in the blood, and circulating in the blood, we have the mannose binding lectin. And if you remember your immunology lectures, the three pathways for activation of the complement system cascade, we have the classical, alternative, and then Mannan pathway, which stands for the mannose, which requires actually the presence of the mannose binding lectins. Lectins means a protein that can bind, strongly bind carbohydrate antigens, certain carbohydrate antigen, and this one can bind to mannose moiety present in these carbohydrates. So lipopolysaccharide is one of the potent foreign molecules that can activate the innate immune system. Lipopolysaccharide, which is present in gram-positive or gram-negative bacteria. Which bacteria have lipopolysaccharide? Anyone?
Gram-negative.
Yes, definitely. Gram-negative bacteria have lipopolysaccharide, which is the endotoxin, and the toxic part is the lipid part. So the lipopolysaccharide has a polysaccharide from the name, plus the lipid, and this can be recognized by toll-like receptors. But toll-like receptors will not recognize by itself. There are cofactors associated with it, such as the MD2 and the membrane-bound CD14. So these act together to recognize the lipopolysaccharide in this case. And this will lead to transfer of an activation signal from the cell membrane to the cytoplasm, and then a second messenger, which is actually a transcriptional factor that will migrate to the nucleus to activate particular genes coding for certain cytokines, mostly in the nucleus of the host cell. And this factor is the nuclear factor kappa B. Nuclear factor kappa B. Kappa is for the light chain of immunoglobulin, B for B cells, but this is a factor that can bind to different types of promoters in the nucleus of the host cell, leading to activation of various cytokines, such as VCAM, ICAM, MCP1, selectins, chemokines, and so on. So some of these are known to be potent pro-inflammatory cytokines, such as tumor necrosis alpha. What is the function of tumor necrosis alpha? What does it do? Why it is so important in sepsis and septic shock? And people have tried before to use antibodies, monoclonal antibodies directed against this tumor necrosis factor in the treatment of septic shock, but it didn't work. Why tumor necrosis factor? What does it do, tumor necrosis factor? It is a pro-inflammatory cytokine. It is released from activated macrophages following their stimulation by whatever, through their toll-like receptors and other type of receptors. So what does it do, tumor necrosis factor? Why it is important in septic shock? It can lead to damage to endothelial cells. It can lead to damage to endothelial cells of blood vessels. It can, through its, induce the production of adhesion molecules that will allow phagocytic cells, such as neutrophils, to home to the site of damage. Normally, this is quite required if you want to get rid of an infectious agent. You want to recruit phagocytic cells and immune cells to the site of infection. But when it is excessive, then there is a problem. So tumor necrosis factor, you know, cytokines can act in various ways. They can act in autocrine fashion. They can act in paracrine fashion. Autocrine meaning on the producing cell itself. Paracrine, they can act on neighboring cells. And occasionally they can act in endocrine fashion. So normally these pro-inflammatory cytokines act in paracrine fashion. But when there is excessive production, then might lead to systemic effects, as occurs in septic shock due to high production of these pro-inflammatory cytokines. So this will lead to affection of wide range or widespread affection of various tissues in the body. And here we are talking about the endothelial cells. So the endothelial cells will be damaged due to release. First of all, there will be a release of vasodilators such as nitric oxide, and this will lead to leakage of fluid from the intravascular to the extravascular space. They can also release other proteases released from activated phagocytic cells and neutrophils, and this can cause collateral damage, not only damage their original purpose is to damage. And sorry, is there any? Okay. Their main purpose. Hello, yes? Anything?
No problem.
I hear these sounds, confusing sounds. Okay, so there will be collateral damage to the endothelial lining cells, and damage to the endothelial lining and also to the loss of integrity of the endothelial lining will lead to loss of fluid from the intravascular to the extravascular space, and also lead to activation of the coagulation cascade through release of tissue factor and von Willebrand proteins, and this will lead to platelet aggregation and microthrombi formation. Normally, if this occurs just locally at a particular site, it's okay, it does not cause much damage, but if it is systemic, then there is a big problem. And in these cases, in sepsis, septic shock, this activation will occur all over the blood vessels in various tissues. And this will lead to what? This will lead to disseminated intravascular coagulation. Disseminated intravascular coagulation will lead to consumption of platelets and coagulation factors, leading to, besides the intravascular thrombi, there will be bleeding tendencies. There will be interference with the blood supply to the tissues, not only due to the thrombi that occur, but due to the release also of to the extravasation of fluid from the intravascular to the extravascular space. So what's the effect of this release or leakage of fluid from the intravascular to the extravascular space? What are the consequences of this leakage of fluid from intravascular to extravascular space?
It could lead to edema.
Yeah, but edema, then what? Just edema, that's it? Yeah, in the lungs, because the lungs are highly vascular organs. So this can lead to the acute respiratory distress syndrome. What else?
It lead to hypotension also.
It can lead to hypotension. Yes. What else? And there will be interference with the diffusion of oxygen, because the fluid would create a barrier between the blood vessel and the tissue cells. So the diffusion of oxygen will be affected. So this will lead again to decrease oxygen delivery to the various tissues and tissue damage. There will be activation also of leukotriene pathways and prostaglandins and various other pro-inflammatory cytokines, interleukin-1, interleukin-6, for example, which are very important in sepsis and also in other types of infections, even viral infections, as you might know, in COVID-19. Interleukin-6 plays an important role, and people have tried to use monoclonal antibodies to interleukin-6 to treat the cytokine storm. What about interleukin-8? What's the function of interleukin-8?
Fever.
It is a chemokine. It is a chemokine that will attract further leukocytes to the site of damage or infection. Okay, you can go through this yourselves, I think. Sepsis and endotoxemia can lead to hypotension, and this hypotension will lead to stimulation of production of vasopressors, catecholamines, and also angiotensin II, and this will eventually lead to renal ischemia and acute renal failure. Also, hyperglycemia occurs in patients with sepsis, due to insulin resistance mostly. People say mainly due to insulin resistance, and this can lead to hyperglycemia, should always be treated in patients with sepsis because it might lead to white blood cell dysfunction and inflammatory reaction. Also, protein C, activated protein C. What happens to activated protein C? What is the function of protein C, activated protein C?
Anticoagulant.
Sorry?
Natural anticoagulant.
Yeah, anticoagulant. So if this is if the production of this factor is interfered with, then this will help in the thrombotic reactions that occur. So it will help in the formation of the DIC. And this will lead to glomerular and vascular microthrombosis. And again, this will end up in acute renal failure. So the kidney is very important organ affected in these cases, besides the lungs, and also besides other tissues, the liver and the brain, central nervous system. This slide actually shows the path of thrombogenesis in normal hemostasis. I leave it to you to go through. So VWF stands for von Willebrand factor. UL stands for ultra large, I think, ultra large von Willebrand, which is abnormal, or some type of von Willebrand factor that will lead to platelet activation and thrombogenesis. So inflammatory cascade, I think I leave this to you to go through. We have talked about the various inflammatory cytokines and the importance of nuclear factor kappa B, which is a transcriptional factor, nuclear transcriptional factor that migrate from the cytoplasm to the nucleus following the activation of phagocytic cells through binding of this molecular pattern or damage associated pattern molecules with their receptors on the surface or in the cytoplasm. Again, all this I leave to you. So this slide shows the table shows the interaction of the various cascade systems. Some of the cascade systems, such as coagulation cascade system, kallikrein system, carcinogen system, here. Others are not shown. Oh, now shown. Yeah. So the complement system and the plasminogen system. So there is interaction between all these systems. Coagulation, you can read yourselves, I think. So SEERS versus CARS. SEERS is the pro-inflammatory and the CARS is the counter inflammatory response syndrome. So there are certain cytokines which counteract the action of the pro-inflammatory cytokines, such as interleukin-4, interleukin-10, and some others too. Etiology, we talked about etiology. This is a partial list of infectious causes of SEERS. You can go through yourselves. Non-infectious. Epidemiology. The true occurrence of SEERS actually is not well known because it is not very clear cut. But following progression of patients with SEERS was noted. This is important. 26% of patients develop sepsis, 18% develop severe sepsis, 4% develop septic shock within 28 days of hospital admission. So the sex-related, probably females are more protected because of the influence of the sex hormone, estrogen. Age-related, of course, the extremes of age, especially aged people with comorbidities, are more severely affected. Mortality. If there is suspected infection without SEERS, it's 2.1%. If there is sepsis, meaning SEERS plus infection, 1.3%. Severe sepsis, 9.2%. When it comes to septic shock, it's 28%. So it's very important to recognize these manifestations of SEERS and sepsis very early and treat them properly. Otherwise, if you wait too long, then it will be irreversible. Key points associated with physical examination, I think you can read yourselves. There is no time to go through all this. Lab tests to consider: blood cultures, urine analysis and culture, cardiac enzymes, amylase, liver profiles, and others. This actually will depend mostly on the treating physician. Estimation of interleukin-6 might be helpful in estimating which patients will develop at increased risk of complications. So if they have high level of interleukin-6, they are more prone to complications. Lactate is of course important because lactate is an indicator of anaerobic metabolism, which is associated with tissue hypoxia. So elevated lactate indicates hypoxia to tissues. Procalcitonin is also have been used as a marker for sepsis. So it can differentiate to a certain extent between infectious and non-infectious causes of SEERS. C-reactive protein, which has been compared with C-reactive protein. C-reactive protein was not that differential value to differentiate between sepsis and non-sepsis or non-infectious SEERS. So procalcitonin is useful, thought to be useful. Presepsin, which is soluble CD14 that we have mentioned before. There is a controversy about this, so I don't think it is recommended. Other lab tests to consider: leptin. Leptin, which is released, as you know, from adipocytes and can affect your intake of food. Might also be helpful, but again, weakly recommended. Therapy, I think therapy I leave to you. Antimicrobial therapy, you have to follow the guidelines that you have in the hospital. antiviral, antifungal, antiviral if you suspect viral infections such as COVID-19 infections or influenza virus infections or other types of infections for which there is antiviral drugs, suitable antiviral drugs. Antifungal therapy might be required if the patient has you suspect to have fungal infection, especially if they are neutropenic, because these patients are more prone to have fungal infections, especially with Candida. Steroids, whether you give steroids or not, again, I don't want to go into this. Glucose control is very important, so you have to control hyperglycemia, as we said, because of its importance in the pathogenesis of sepsis and septic shock. So you have to treat the hyperglycemia. Supplemental oxygen, I think I leave to you. Updated bundles in response to new evidence. So you have to measure lactate, obtain blood cultures prior to administration of antibiotics. This is important. You have to get the blood culture before. And this applies for types of conditions, infectious conditions. You have to take blood culture before giving antibiotics. Otherwise, if you give antibiotics and then take blood for culture, you might have false negative results. Whether to administer broad spectrum antibiotic, again, the type of antibiotic depends on the guidelines you have in the hospital. And then to fluid replacement using crystalloids for hypotension. Giving vasopressors. So all this, I leave it to you, and the guidelines and the available in the hospital. Recent clinical advances include therapy with activated protein C. This is still, I think, controversial. Tight glycemic control is important. This is important to control the blood glucose level because it is involved with the oxidative stress and damage to the endothelial lining of blood vessels, which lead to the refractory septic shock. So it is important to have a tight glycemic control. Early goal-directed therapy is important. So you don't wait until the condition has advanced and become reversible. Modulating the immune response in the light of the characteristic of specific pathogen, genetic profile of the patient, duration of the disease. This is not yet, but of course you can treat cytokine storms by giving anti-cytokine directed therapy. And that's it, I think. Thank you very much for listening.
Thank you so much, Prof.
Thank you so much, Prof.
For the interesting talks.
Do you have any questions?
Any question from the floor?
Yes. Good afternoon, Prof.
Yes, good afternoon.
I have a question. Do we
Yes.
still have a term called hyperdynamic septic shock?
Hyperdynamic septic shock.
Yeah, I went through this in our Christian Bank of MCQs, but I could not find it in the books.
I know hyperdynamic circulation, which can occur in various conditions such as anemias. Hyperdynamic septic shock. I'm not sure of this. I think I have to read about it. I don't know. I'm not sure.
Okay, thank you, Prof.
Thank you. So why anemia occurs in patients with sepsis and septic shock, besides the suppression of the bone marrow that you have mentioned before?
I think the anemia due to the iatrogenic hemolysis of the blood. Due to
Hemolysis is
sepsis.
due to
Hemolysis due to infection or peripheral consumption.
peripheral consumption of the coagulation factors and platelets,
Yeah.
but not the RBCs. Bleeding might lead, if there is bleeding, of course, that might lead to anemia, but what else? As a result of the DIC, what happens in patients with DIC? They can develop microangiopathic hemolytic anemia.